Hi everyone, good evening. Am I audible and visible? If I'm audible and visible, can I see a thumbs up on the live chat please? If I'm audible and visible, can I see a thumbs up on the live? So, welcome, thank you Bharat Kumar. Thank you, Chota Doctor. So, welcome to the session, which is Biochemistry recall session of the latest NEET PG 2024. And before we start the session, let me give you a good news. We are launching our Rapid Revision 6.0 on 16th August 2024. And what is great about this? Yes, there are so many advantages if you utilize this Rapid Revision series. Here we have 260 plus hours of video lectures. Not just that, we have 2,500 high yield MCQs, and that comes along with concise notes. Yeah, so make the most use of this part of PrepLadder platform. And about the session today, let me start the session with a disclaimer. The questions discussed in this PowerPoint are purely recall based, and the ultimate motive of this live session is to get the actual questions from all of you through this discussion. Yeah, and once we get all final questions, that will be uploaded on the PrepLadder app. And then now a summary of what you can expect in this session. So in both the sessions put together, in NEET PG 2024, there were 31 MCQs in biochemistry. And what is strikingly interesting here is, out of these 31 MCQs, 16 MCQs are clinical biochemistry MCQs, which include MCQs on glycogen storage disorders, alcohol metabolism, arterial blood gas analysis report interpretation. There was one question, but hyperlipoproteinemias were covered in and out, right? There were many questions on type 2A hyperlipoproteinemia or familial hypercholesterolemia. They had also asked you about familial chylomicronemia syndrome, and all these we had already discussed in detail. Right? So 16 MCQs were clinical biochemistry MCQs. And as always, vitamins, there were 7 MCQs, genetics 3. In electron transport chain, in both the sessions, there were one question each, and both were related to electron transport chain inhibitors. And then metabolism, core metabolism, I could see only one MCQ. Yeah, even that was related to GLUT transporter, not exactly like rate limiting enzyme or energetics. So what am I trying to tell you all here? When you learn biochemistry, it is not just about learning those pathways and cycles, right? It's all about learning the applied aspect of biochemistry. And that being told, I'm not here to recommend that you should learn only clinical biochemistry, because you cannot straight away go and learn clinical biochemistry. So my point here is, start learning all pathways, start learning all cycles, but do not stop there. Yeah, you should try to understand how to apply your knowledge clinically, and only then you will be able to answer all these MCQs. Okay, and there was one question on mineral, and as always there was one question on enzymology, which is related to enzyme inhibition. And they had given you a Lineweaver-Burke plot, and they asked you to find out which type of inhibition it is. Okay, so that's a summary of what you had in the NEET PG 2024 exam paper in both the sessions put together. Okay, so let's start discussing these MCQs quickly. This is the first question. 26-year-old male with colicky pain, and the crystals in urine picture is given below. Which of the following is the diagnosis? So what is the right answer? Before you can start guessing out, before you start getting anxious, let me tell you the answer first, and then I'll tell you why this is the right answer. The right answer is cystinuria, because there are two clues here. One is colicky pain, which means there are renal stones. And what kind of crystals do you see? Hexagonal crystals. Hexagonal, I've asked you to remember it as 6. Yeah, hexagonal meaning 6 sides. 6 and cis sound similar, right? 6 and 6 sound similar. So hexagonal crystals are features of cystine urea. So what will you find in cystine urea? It will present as recurrent renal stones, recurrent obstructive uropathy. So the answer here is cystine urea because it is hexagonal crystals. Now a quick recap on other types of crystals that you can see as an image based question, because some of you who are attending this might be aiming for the next NEET PG, right? Because this YouTube video will be later on watched by NEET PG aspirants. So for their benefit, I'm going to show you other images related to urine crystals as well. So what kind of crystals do you see here? These are called as rhomboid crystals. This is a rhomboid shape, right? And rhomboid, you can remember U, yeah, uric acid crystal. So if it is a hyperuricemia related uric acid renal stones, then what kind of crystals will you see? Rhomboid crystals. Now what if you see something like this? Do you see an X in the center? Yeah, X stands for oxalate. So oxalate dihydrate crystals, yeah, calcium oxalate dihydrate crystals will be envelope shaped with an X in the center. Okay. What if it's calcium oxalate monohydrate? Monohydrate crystals will be dumbbell shaped. Don't you see that here? It will be dumbbell shaped. So this is calcium oxalate monohydrate crystals. Now what about this? This is calcium phosphate crystals. You know, normally calcium and phosphate are present in urine, but in some conditions, for example, dehydration, when the urine is concentrated, then you will start seeing calcium phosphate crystals as well. In that case, you will see rectangular crystals which are arranged in a fan-like manner. Yeah, if you see something arranged like a fan, then that is called as calcium phosphate crystals. And then the most severe of all urinary crystal is this. Do you see a coffin lid appearance here? Yeah, coffin lid appearance that is seen in the most severe of all renal stones, which is true white stone. So what do you mean by true white stone? Magnesium ammonium phosphate or triple phosphate stones will occupy the entire pelvic-calyceal system. That's called the true white stone, and that will look like a coffin lid. So these are the renal stone appearances that you should remember. But for now, the answer here is cystine urea because it's a hexagonal crystal. Okay. A patient presents with symptoms of dermatitis, dementia and cognitive decline, right? There is no exam without this question, I guess. Because even the latest FMG, there was a question, exactly similar question. So what do you see here? Diarrhea, dermatitis and dementia. Okay, 3 Ds of pellagra. And they're asking you which micronutrient deficiency is most likely responsible. Pellagra is caused by niacin deficiency. Okay. Another niacin based question. A farmer is on a maize based diet. We have learnt always that maize has got poor availability of tryptophan. So anybody who is on a maize based diet will not have tryptophan in the diet. Without tryptophan, what cannot be synthesized? Niacin cannot be synthesized. Without niacin, what will be the manifestation? 3 Ds of pellagra. 1 D is dermatitis. And that is why this farmer is presenting with skin rashes in the photo exposed area, sun exposed area, namely face, neck and hand. So this is again pellagra because of maize based diet, because bioavailability of tryptophan from maize is low. When there is no tryptophan, niacin cannot be synthesized. So this person has to be supplemented with niacin. Okay. The next MCQ. Which micronutrient deficiency causes anemia, bleeding gums and white line of Frankel on X-ray? Yeah, this is nothing but scurvy. Right? Scurvy is vitamin C deficiency. And if you're wondering why should vitamin C deficiency cause anemia, because vitamin C is a reducing substance which has to reduce ferric ion that is present in the diet to form ferrous, and only in the form of ferrous ion it can be absorbed into the circulation. So whenever there is vitamin C deficiency, ion absorption is affected and that causes anemia. Why will you see bleeding gums in vitamin C deficiency? Because vitamin C is necessary for collagen maturation. without collagen being matured, all blood vessels will be weak and that causes bleeding gums. Okay, and you will see excessive calcification on X-ray, which is seen as white line of Frenkel. So this is nothing but scurvy caused by deficiency of which vitamin? Vitamin C. Okay, a quick recap on vitamin C and collagen maturation. Vitamin C is necessary as a coenzyme for prolyl hydroxylase and lysyl hydroxylase. And both prolyl hydroxylase and lysyl there was no vitamin C. What were the other choices, please? Only prolyl hydroxylase. This is second shift question. Yeah, I have both first and second shift questions. Put together, I have 31 MCQs. Okay. So, prolyl hydroxylase and lysyl hydroxylase are necessary for collagen maturation, without which there can be bleeding gums. Okay. Which of the following is deficient in a patient with phenylketonuria with normal phenylalanine hydroxylase levels? What will be the right answer? I think this was the first session question. Phenylketonuria is caused by the defect of phenylalanine hydroxylase. And what is the role of phenylalanine hydroxylase? It should convert phenylalanine to tyrosine. And for this conversion, without vitamin C. So can you tell me what were the other choices? We'll go back to that MCQ. Yeah, I'm seeing the comment. Yes, Saif. What were the other choices? If not vitamin C, what were the other choices? Okay, junior surgeon. Was that copper, iron, zinc? What was the fourth option? I'm not sure, but only minerals. Okay. Okay, with copper, zinc, iron, no bleeding history. Okay, hair changes were mentioned. Okay, so I think it is copper deficiency, and assuming that the features were anemia, neutropenia. Am I right? All of you? Anemia, neutropenia, and white hair. Hypopigmentation of hair. Did you see all of that? Depigmented hair. Good. Yes, I have that MCQ also. Probably some student got confused between these two questions. So there is another MCQ which I'll be discussing. Anemia, neutropenia, hypopigmentation. So that is because of copper deficiency. So answer for this question would be copper. Why should copper deficiency cause anemia? Can anybody try to understand? Can anybody try to explain? Because copper is necessary for ceruloplasmin. And ceruloplasmin is a ferrioxidase which is necessary for iron transport. And that is why copper deficiency will cause iron deficiency anemia. Okay. And why should copper deficiency cause neutropenia? Neutropenia because copper is necessary for superoxide dismutase, which is one of the enzymes which is necessary for keeping neutrophils active. So when there is no superoxide dismutase, that will cause neutropenia. And why do they present with depigmented hair or white hair? Because copper is necessary for tyrosinase, which is necessary for converting tyrosine to melanin. So let me remove this MCQ. Anemia, neutropenia, depigmented hair because of deficiency of copper. Have I answered everybody's question? Good. I'm seeing the comment side. Is there anything else that you want to know? Can we go to the next question? So answer for that question is copper. Okay. Which of the following is deficient in a patient with phenylketonuria with normal phenylalanine hydroxylase activity? So phenylketonuria is caused by low activity of phenylalanine hydroxylase, which is necessary for converting phenylalanine to tyrosine. But for this we need a coenzyme which is tetrahydrobiopterin, and during this chemical conversion it gets converted to dihydrobiopterin. So how do you regenerate tetrahydrobiopterin? By dihydrobiopterin reductase. So phenylketonuria is not only caused by a genetic defect of phenylalanine hydroxylase, it is also caused by the defect of dihydrobiopterin reductase. So what is the right answer? Fluoride was there in the option. Fluoride, No, that does not cause any of these manifestations. Okay. So what is the right answer here? The right answer here is dihydrobiopterin reductase. The next question, all of you. A 5-year-old girl was washing her doll with shampoo containing rotenone. So this we have discussed so many times in our sessions, right? Rotenone has got what at the end? 1. And I told you rotenone inhibits complex 1. So it inhibits electron transport between complex 1 and Q. And what is complex 1? Complex 1 is NADH linked dehydrogenase. So rotenone inhibits what? It inhibits NADH linked dehydrogenase. Is that clear to all of you? The answer is choice A. Okay. One more question on electron transport chain is this. What is this question? A patient is being treated with phenobarbital. I told you amobarbital, right? Amobarbital and all barbiturates. A. So it inhibits electron transport between complex 1 and Q, right? So phenobarbital also inhibits electron transport between 1 and Q. So this we have discussed in detail in all our sessions, right? So a patient presents with an X-ray showing cardiomegaly along with symptoms of hypotonia, macroglossia. This was a first shift and previous one was a So along with symptoms of hypotonia, macroglossia, hepatomegaly and floppy baby syndrome. So we have classically discussed all this, right? And these are the features of Pompey's disease. How did I ask you to remember Pompey's disease? I said in Pompey's disease, the pump gets affected. Which is the pump of your body? Heart gets affected. And that is why it presents with cardiomegaly, cardiomyopathy. When hepatomegaly, with floppy baby, with hypotonia, macroglossia, right? So if at all they have to give you an X-ray for transposition of great arteries, what do you think they would have given? Right? They would have given egg on string appearance. They are not going to give you cardiomegaly. So the answer is Pompey's disease. Which of the following are methanol poisoning derivatives? Let me tell you the answer first and then let me explain you why. On methanol metabolism, it becomes formic acid. So one metabolite is formic acid. The other metabolite is lactic acid. Phenobarbital was asked, not paracetamol. Yeah, I showed you the question is phenobarbital. Yeah. So what is the right answer? The right answer here is formic acid and lactic acid. So the right answer is choice B. Let me tell you why. Okay. So as I've always been telling you, whenever somebody tells you a fact or concept, you should ask why, right? So what happens when methanol is metabolized? Methanol is CH3OH. It gets metabolized by alcohol dehydrogenase to form formaldehyde. Then aldehyde dehydrogenase converts it into formic acid. And that is why formic acid accumulates. And this formic acid inhibits electron transport chain. Yeah, particularly cytochrome C is inhibited by formic acid. What will happen when electron transport chain is inhibited? Oxidative phosphorylation does not happen. No aerobic metabolism, only anaerobic metabolism that causes lactic acidosis. So what will you see in methanol poisoning? In methanol poisoning, you see formic acid and oxalic acid. No, formic acid and lactic acid. So interpret the following ABG report. Have we discussed about this? Yes, we discussed this even in the LRR session. Remember? So pH is 7.21. What was the right answer? What did you all choose for this? Wasn't there a lady consuming paracetamol tablets, or did I read that wrong in the first shift? Yeah, all of you please help Shifa to find out whether that question was asked. So before that, let's try to solve this MCQ. 7.21, pH normal is 7.36 to 7.44. Here the pH is low, so we know it is acidosis. Then to find out whether it is metabolic acidosis or respiratory acidosis, look at PCO2. Normal PCO2 is 36 to 44 millimeters of mercury. In this case, PCO2 is low. Can a low PCO2 explain acidosis? No. Low PCO2 can only explain alkalosis. So low PCO2 is not the primary acid-base disorder in this patient. So check bicarbonate. Bicarbonate is 6.3 milliequivalents per liter. Normal bicarbonate is 21 to 27 milliequivalents per liter. In this case, bicarbonate is low. So we know it's a case of metabolic acidosis. Now look at all these four choices. Among these four choices, what is the only choice wherein you see metabolic acidosis? Choice B. So you can straight away choose choice B. So it is metabolic acidosis with partial compensation with high anion gap. Let me explain this further. How do you calculate compensation? I said in compensation, the compensation is always parallel. So if the primary defect is a decrease in bicarbonate, which is seen in metabolic acidosis, the compensation should be a decrease in PCO2. How much decrease in PCO2 do you expect? Expected PCO2 in metabolic acidosis is, I've asked you to calculate using Winter's formula. What is Winter's formula? 1.5 into bicarbonate plus 8. So it is 1.5 into 6.3 plus 8, which is, if you take it as 6, 1.5 into 6 is 9, 9 plus 8 is 17, right? It's almost compensated, right? It's almost compensated. So it is compensated metabolic acidosis. I also told you whenever it is metabolic acidosis, you should be calculating the anion gap. What is the formula for anion gap? Anion gap is sodium minus within brackets chloride and bicarbonate. If pH of 7.4, what would be? I will tell you about that. So how will you calculate anion gap? Anion gap is sodium minus within brackets chloride and bicarbonate. Sodium here is 127 minus chloride is 101.7. plus bicarbonate is 6.3. So 127 minus 10.7 plus 6.3 is 17. Am I calculating it right? Sodium minus 101.7, right? So 101.7 is 108. So 127 minus 108 is 19. What is the normal anion gap? Normal anion gap is 12 plus or minus 2. Right, normal anion gap is 12 plus or minus 2. In this case, it's 19. So it is increased anion gap metabolic acidosis, which is compensated. So the right answer here is choice B. Okay. Next question. Patient with high triglyceride esterified with long chain fatty acid. That is the clue here. Presents with fatigue and biopsy of muscle shows fat vacuoles. Which of the following is the diagnosis? So triglyceride esterified with long chain fatty acid tells you that there is some defect of fatty acid oxidation. Okay. When will there be fatty acid oxidation defect? Whenever there is carnitine deficiency. Because we have learnt that carnitine is necessary to transport long chain fatty acids across the mitochondrial membrane. So whenever there is carnitine deficiency, long chain fatty acids accumulate, and without fatty acid oxidation, cardiac muscle fibers and red muscle fibers get affected. Right? Have I told you? Fatty acid is the preferred fuel for cardiac muscle fiber and red muscle fiber. And that is why there is fatigue. And biopsy of muscle also shows fat vacuoles. So all these are consistent for what? Carnitine deficiency. We can exclude fatty acid synthase defect because I told you in all my sessions that there is no inborn error of metabolism related to fatty acid synthesis, because any fatty acid that is present in the diet is sufficient to meet our demands. Okay. And lipoprotein lipase defect will be called as familial chylomicronemia syndrome, which can definitely present with hypertriglyceridemia. But will you see fat vacuoles in the muscle? You will not see fat vacuoles in the muscle, because when lipoprotein lipase is defective, from lipoprotein fatty acids cannot enter into muscle. So muscle will not have triglyceride, muscle will not have fatty acid. Do you understand this? That is why it is not LPL deficiency. LDL defect will present with hypercholesterolemia. Yeah, it will present with hypercholesterolemia, not with hypertriglyceridemia. Okay. So answer for this question is carnitine deficiency. This is why I say you have to learn in everything in an applied manner. Only then whenever they ask you a question which is twisted. Till now they've never asked you a question on carnitine deficiency. This time they've asked you. Which means if you learn everything in an applied manner, even if it's a twisted question, you'll be able to apply it and you'll be able to exclude choices. Okay. Patients with xanthomas on Achilles tendon. Tendon xanthomas. What have I told you? Whenever you see tendon xanthomas, you should suspect hypercholesterolemia. Whenever you see eruptive xanthomas, you should suspect hypertriglyceridemia. So, tendon xanthomas means it is familial hypercholesterolemia. Very good, all of you. There was another question with abdominal pain. Yeah, I will show you that. So, answer is choice A. What is the source of vitamin B1 or thiamine? Yeah, I was told that something like this, a plate with which is a mixed balanced diet was shown, and you were asked to find out of these what can act as a source of thiamine. Thiamine source is whole grain, like rice. Yeah, till some time back we were polishing rice, and that is why rice did not act as a source of thiamine. But now we are parboiling rice, and parboiled rice will act as a source of thiamine. Do you understand this? So what is the right answer? There was a first shift question. Apolipoprotein defect has chylomicronemia. That question is there. I will discuss that. I have taken all MCQs. Together we are going to discuss 31 MCQs. Yeah. So you have to just be patient, listen to all MCQs, you get an answer for every MCQ. Okay. So whole grain, that is rice, will act as a source of thiamine. A patient came to the emergency room with severe pain in the abdomen. Do you get this question now? Yeah? Yes. So with severe pain in the abdomen, severe serum triglyceride level was 1500 milligram per deciliter. So severe pain in the abdomen, probably because of pancreatitis. You see pancreatitis with massive elevation of triglyceride 10 times higher than normal value. So what is it? It is familial chylomicronemia syndrome. Xanthomatosis was there in the option. In which question, Prashant? So this is familial chylomicronemia syndrome caused by the defect of ApoC2 or lipoprotein lipase. Tendon xanthomas, abdominal pain. Options were Fabry's Tangiers. Neither Fabry's nor Tangiers present with tendon xanthomas. You know that, right? Fabry's will present with angiokeratomas. Tangiers disease will present with grayish orange tonsils. So it is neither Fabry's disease nor Tangiers disease. Okay, tendon xanthoma. So whenever you see tendon xanthoma, it should be related to hypercholesterolemia. Do you all understand this? So the answer should be either LDL receptor defect or ApoB100 defect. Did you all see apolipoprotein there? If you had seen apolipoprotein, you should choose ApoB100. Familial hypercholesterolemia, yes. Okay, so this is the clue. Tendon xanthomas, familial hypercholesterolemia. Massive elevation of triglyceride with recurrent pancreatitis, that is familial chylomicronemia syndrome caused by the defect of ApoC2. Yeah, LDL receptor defect was given in the choice is what I was told. Okay. So are you talking about this one, all of you? A patient has multiple tendon xanthomas again. This is the third MCQ on familial hyperlipoproteinemias. So patient has multiple tendon xanthomas. Serum cholesterol is elevated. Normal is 200. In this case, it's elevated. And LDL level was also elevated. What is the defect? What is the right answer? It has to be LDL receptor defect. LDL was not cleared. An LDL receptor defect, right? So this is the right answer. I hope it's clear to all of you. In evening shift, Proteus was asked, stone due to Proteus, but in options, no phosphate was mentioned. Can they cause cystine stones? No, they don't cause cystine stones. Xanthomatosis was there in the option. Yeah, so had they asked you about Proteus, did you see any phosphate stone in the choice? All of you? Let me help you answer that question. In the question on Proteus, did you see any choice with phosphate? It can be magnesium phosphate, ammonium phosphate or calcium phosphate. In that case, that would be the right answer. Have I given you the right answer? Yeah? Good. So, can we discuss the next MCQ? Good. A 13-year-old boy reported with jaundice, fatigue, muscle stiffness, tremors and behavioral changes. Okay. They have classically given you KF ring. Okay. Examination revealed an enlarged liver and spleen. The moment you see KF ring, you know it is ceruloplasmin deficiency or it is Wilson's disease, right? So we know the diagnosis Wilson's disease, but the question is definitive diagnosis is done by what? Definitive diagnosis is by liver biopsy, where you measure liver concentration of copper in liver cells. Yeah, that will be the definitive diagnosis. Okay, so let me tell you few facts about Wilson's disease and then I'll tell you about diagnostic investigations for Wilson's disease. Wilson's disease is caused by the defect of ATP7B gene, and the protein that is coded by this gene has got two functions. One is it helps in excreting the excess copper into bile. The other one is it helps in incorporating copper into apoceruloplasmin, forming ceruloplasmin. So when there is no excess copper that is getting drained into the bile, there will be copper toxicity. And this copper toxicity causes hepatolenticular degeneration. Only because there is hepatodegeneration, you see hepatomegaly, jaundice, right? So all these are because of hepatolenticular degeneration. Lenticular meaning lenticular nucleus is affected, and that is why muscle stiffness and tremors. And apart from this, when copper does not get incorporated into apoceruloplasmin, ceruloplasmin is not formed. Ceruloplasmin is not stable. So when ceruloplasmin is not formed, the first diagnostic investigation that you can do is estimate serum ceruloplasmin level, which will be less than 0.2 gram per liter. Okay, serum ceruloplasmin level will be less than 0.2 gram per liter. But this is a non-specific investigation. Okay, additionally, there will be low serum copper. This is a paradox. This is a disorder of copper toxicity with low serum copper, because copper gets excreted in urine because copper is not getting protected by ceruloplasmin. So serum copper is low, but urinary copper will be high. And whenever urinary copper concentration is more than 100 microgram in 24 hours urine, yeah, urinary copper more than 100 microgram in 24 hours urine, that is diagnostic. I won't say diagnostic, that is also indicative of Wilson's disease. Once you see these two findings, low serum ceruloplasmin, high urinary copper, then you can ask for liver biopsy, which is the confirmatory test. So on liver biopsy, if liver shows more than 250 microgram of copper per gram of tissue, if liver biopsy reveals more than 250 microgram per gram of dry liver tissue, then that is diagnostic of Wilson's disease. Do you all understand this? So what is the right answer here? The right answer here is hepatic parenchymal copper concentration is the definitive diagnosis for Wilson's disease. So what did I tell you about Wilson's disease? You see a paradox, copper toxicity with low serum copper, high urinary copper. Okay. A patient's relatives sent message on social media to the consulting doctor. He is unaware about other investigations, but he mentioned that urinary coproporphyrin is positive. And they have given you few occupational disorders. What is the probable cause? I would say it's a very simple question. Urinary coproporphyrin being positive is indicative of what? Lead poisoning. Because lead inhibits ALA dehydratase. In a patient with lead poisoning, ALA levels will be elevated. Because lead also inhibits coproporphyrinogen oxidase, urinary coproporphyrinogen levels will be high. And lead also inhibits ferrochelatase. Yeah, it also inhibits ferrochelatase, and that is why there is an elevation of zinc protoporphyrin levels. So all those NEET PG aspirants who are going to prepare for the next exam, yeah, please understand these are the 3 diagnostic markers of lead poisoning. What will you see in lead poisoning? Number 1, elevated serum ALA levels. Number 2, elevated coproporphyrinogen in urine. Because it inhibits ferrochelatase, iron cannot get chelated into protoporphyrin ring. Instead, zinc gets chelated. So, there will be an elevation of zinc protoporphyrin levels. Okay. So, answer is lead poisoning. We have discussed all these in our LRR session, right? I told you about this. A neonate was brought to the hospital with chief complaints of poor feeding, vomiting, acidosis and cataract. Okay, Benedict's test on urine was positive, but urinary glucose was negative. So what does this mean? If urine Benedict's test is positive but it's not glucose, it means urine has got a reducing substance which is not glucose. A reducing substance which is not glucose can be galactose or fructose. But in this case, because they've told you that there is cataract, it is galactosemia. Because I told you fructose metabolism disorders do not that commonly present with cataractous changes. So Benedict's test being positive, urine not having glucose, meaning there is either galactose or fructose. Because a child presents with cataractous changes, you know it is galactosemia caused by the defect of galactose 1-phosphate uridyl transferase. Okay, this is classical galactosemia. Vomiting after milk, which enzyme deficiency? Was that lactase? Child, was that lactase? I like your name. Yeah, if it was lactase, then that is the right answer. Good. Thanks for giving me one more question. So, a patient with history of binge alcohol. So, when I saw this MCQ, I felt as if somebody watched a session and then framed this question. Right? Because in LRR session, I exactly told you this. So, a patient with history of binge alcohol intake presented to the emergency department with convulsions, altered sensorium and plasma glucose level was low. And I told you alcoholism makes a person susceptible to repeated episodes of hypoglycemia. And that is what is given as the history. Now, which of the following treatment is needed? In a normal person with hypoglycemia, the treatment would be just dextrose. But if the person is a chronic alcoholic, do not start dextrose immediately because that will cause Wernicke's encephalopathy. Right? So, to prevent Wernicke's encephalopathy in a chronic alcoholic, before you start dextrose, first supplement thiamine and then start glucose. Because when you start glucose, glucose gets metabolized to form pyruvate. For further metabolism of pyruvate, which enzyme is necessary? PDH complex is necessary. That PDH complex needs thiamine. So, without giving thiamine, if you start dextrose, PDH complex will be using more and more thiamine. So, the person becomes suddenly overtly thiamine deficient, and that is called as Wernicke's encephalopathy. To avoid Wernicke's encephalopathy, what will you do? You first start thiamine and then give dextrose. Clinical picture of scurvy was given, but the question asked was what is the micronutrient deficient associated with it, and you opted iron. Yeah. So I think we discussed that MCQ. It was almost like anemia, neutropenia, depigmented hair. Is that what you're saying? Priyanka, hi Priyanka. Good to see a radio resident watching this session. I appreciate your interest in biochemistry even after joining radiology. Hi Priyanka. So what is the right answer? The right answer is thymine followed by dextrose. Okay. So crumpled tissue paper appearance and pancytopenia are seen in which of the following enzyme defects? So classical, am I right? Crumpled tissue paper appearance, pancytopenia, what is it? Gaucher's disease. And Gaucher's disease is caused by the defect of beta glucosidase or beta glucosyl cerebrosidase. So what is the right answer? The right answer is, oh yeah, hi Priyanka, I remember you. So what is the right answer? The right answer is glucocerebrosidase. Okay. Alpha answer for Peach question. So Peach, can you tell me those features that were asked? Exactly. I can see that you've written it as curvy. Other than, instead of just saying it as curvy, what were the manifestations that were asked? If you can say that, I'll be able to help you with the right answer. So alpha glucosidase defect is Pompey's disease. Beta galactosidase defect is GM1 gangliosidosis. Alpha galactosidase defect is Fabry's disease. In none of these conditions, you would see crumpled tissue paper appearance. So this is beta glucosyl cerebrosidase. A mother came to the OPD with 14-year-old boy, mentally retarded, complaining of joint pain, irresistible urge to bite his fingers and lips. Right? Self-mutilation. Yeah, lactase deficiency we discussed. Thank you. Say what I feel reasonable. Okay. Yeah, self-mutilation with high uric acid. Then what is the diagnosis? The diagnosis is Lesch-Nyhan syndrome caused by the defect of hypoxanthine guanine phosphoribosyltransferase transferase enzyme. Right? So what is the right answer? The right answer here is choice A. In scurvy question, another option was fluoride. Yeah, so if you found that there was white line of Frenkel, and if you see fluoride, then that can be chosen, Ashia. Thanks for giving me the answer. Okay. Skin rash which get exaggerated on sun exposure, right? So skin rash which gets exaggerated on sun exposure, repair mechanism involved in the above condition. So this is xeroderma pigmentosa, and I asked you to remember it as nucleotide excision repair mechanism. So xeroderma pigmentosa is caused by, yeah, I have that question also. So xeroderma pigmentosa is caused by the defect of nucleotide excision repair mechanism. That we discussed already. The next question, a 45-year-old patient presented with joint pain, weakness. Patient has a history of homocystinuria. Which vitamin is required in the treatment? Okay, so joint pain, weakness with homocystinuria. Then what will you give? Homocystinuria can be treated by giving B6, B12 and folate. Biochemistry seems like the only one which was a relief. I am so happy to hear that, right? This means you have understood biochemistry conceptually, and that is why you were able to answer all these questions. Okay, so you can choose one of these three, B6, B12 and folate. Given a choice, I would go for B6 because B6 is necessary for cystathionin beta synthase, which helps in the conversion of homocysteine to cysteine. And that is the major fate of homocysteine. So whenever somebody presents with homocystinuria, it is better to start with B6 because all homocysteine can become cysteine. And you can add B12 and folate also, because when you add B12 and folate, homocysteine can become methionine. Okay, so the answer would be B6. So, did you all see this question? I was told that there was an image-based question on Prader-Willi syndrome, wherein they had shown you that chromosome 15, long arm, there is a deletion. Okay, so I chose this image. Given below is a diagrammatic representation of karyotype of an individual. What is the diagnosis? So what you see here, all your chromosomes are seen, and then chromosome 15, the long arm has undergone shortening. That is deletion of long arm of chromosome 15. And there is a label, this is maternal chromosome, this is paternal chromosome. And whenever there is a micro deletion of long arm of chromosome 15 in the paternal chromosome, that's called as Prader-Willi syndrome. Whenever there is micro deletion of long arm of chromosome 15 in the maternal chromosome, that will cause Angelman syndrome. Because here there is a deletion in the paternal chromosome, what will be your answer? The answer will be Prader-Willi syndrome. Okay. A bit about Prader-Willi syndrome and Angelman syndrome. Okay. So this is about chromosome 15. This is the short arm and this is the long arm. And long arm, this is the maternal copy, this is the paternal copy. Interestingly, the long arm of chromosome 15, both in the paternal copy and maternal copy, one segment is imprinted. What do you mean by imprinted? One segment is silenced because of methylation. Okay. And whenever there is a micro deletion involving paternal chromosome, this part will be lost. When that part is lost, the maternal copy, okay, so what did I tell you? One part, one second. So in the long arm of chromosome 15, let me show you the imprinted part as red color. So this part is imprinted in the maternal copy and this part is imprinted in the paternal copy. Okay, and whenever there is a micro deletion involving the paternal chromosome, when this is lost, even the normal part that should be shown by the paternal copy is lost, and that causes Prader-Willi syndrome. When this part is deleted, that causes Angelman syndrome. Okay, so the answer here is Prader-Willi syndrome. Paternal and maternal were labeled. Good. If paternal was lost, it is Prader-Willi. A patient who has always neglected his nutrition presented with follicular hyperkeratosis. This also we have discussed in detail. Follicular hyperkeratosis is seen in vitamin A deficiency and that's called as frenoderma. Yeah, so what is the right answer? The right answer is frenoderma. ApoB48 defect does not cause type 1. Do you all understand this, Dr. Babu? What you have asked is reasonable. Okay, you are asking when type 1 hyperlipoproteinemia, there is hypertriglyceridemia with abdominal pain. Now it is because of chylomicron elevation, then why can't I answer it as ApoB48 defect? Because even if there is ApoB48 defect, you will not see familial chylomicronemia syndrome. ApoB48 is not involved in the metabolism of chylomicron. What is involved in the metabolism of chylomicron? Only ApoC2. Do you get it? Yeah. So the answer for that would be only ApoC2. A diabetic patient came to the OPD and physician advised exercise. Which of the following So which of the following glucose transporter is insulin sensitive? So what will happen when you work out? When you work out, your muscle will upregulate GLUT transporters. Which GLUT transporter will it upregulate? GLUT4 transporter. Normally, GLUT4 transporter upregulation is dependent on insulin. And when a person has got insulin resistance, to overcome the insulin resistance, if you work out, for that purpose, GLUT4 transporters will get upregulated. So insulin dependent glucose uptake happens in skeletal muscle, cardiac muscle and adipose tissue by GLUT4 transporter upregulation. Okay. Will overcome. Probably the question was which will overcome insulin resistance. Do you understand my point? The person is insulin resistant. So through insulin, GLUT4 transporter cannot be upregulated. So what is the alternative way of upregulating GLUT4 transporters? By exercising. And that is why you should advocate exercise in a person with insulin resistance. So that is GLUT4 transporter. So patient with anemia, neutropenia, hypopigmentation of skin and hair, we discussed this MCQ already. It is copper deficiency. Because I told you what is copper needed for. Copper is necessary for ion transport, because copper is necessary for ceruloplasmin, and ceruloplasmin helps in the conversion of ferrous to ferric ion, and this ferric ion will be transported in the blood in the form of transferrin. So whenever there is copper deficiency, ion transport does not happen, that causes anemia. And whenever there is copper deficiency, there will be neutropenia, because neutrophils will not have superoxide dismutase activity. They present with hypopigmentation because tyrosinase is dependent on copper. So what is the right answer? The right answer is copper. A patient came to the hospital with severe abdominal pain and lipase levels were elevated. On imaging, a stone is found in the common bile duct. So do you now understand why abdominal pain and lipase elevation? It is because of pancreatitis caused by common bile duct obstruction. Which enzyme is elevated in this condition? Whenever there is a biliary duct obstruction, an enzyme which is present along the biliary ductule will be released into the circulation. And the most sensitive marker for bile duct obstruction is GGT. So the first one to be elevated is GGT. That will be followed by alkaline phosphatase, and sometimes 5' nucleotridase will also be elevated whenever there is bile duct obstruction. So sensitive marker for bile duct obstruction is GGT. Okay. So this MCQ, a child presented with the following deformity. What do you see? Knock knees, genu valgum, right? Biochemical investigations are given below. Serum calcium is normal. Yeah, PTH value is normal. Phosphate is low. Alkaline phosphatase is raised. Which is the probable defect? Let's start excluding choices one by one. I am going to exclude vitamin D deficiency first. But before that, let me give you the right answer. I know you're all anxious to know the answer. The answer is hypophosphatemic rickets. Yeah, answer for this is hypophosphatemic rickets. If you're asking me why, I am choosing this because of two reasons. One is phosphate level is low. The other reason is PTH level is normal. And that is why I've excluded all other choices. Okay, so answer is hypophosphatemic rickets. Now let me tell you why. What happens in vitamin D deficiency? Whenever there is vitamin D deficiency, there will be low calcium and low phosphate. Whenever there is low calcium, that stimulates parathormone secretion. So this causes secondary hyperparathyroidism. So in vitamin D deficiency, nutritional vitamin D deficiency, PTH levels will be high. Okay. When PTH levels are high, PTH will cause calcium reabsorption. This calcium reabsorption might make the calcium level to look normal. So even in nutritional vitamin D deficiency, calcium level can be still normal. But what will happen to phosphate level? Already because of vitamin D deficiency, phosphate levels are low. Now because of secondary hyperparathyroidism, phosphate level is still low because parathormone causes phosphate secretion. So what will you see in nutritional vitamin D deficiency? In nutritional vitamin D deficiency, you will see normal calcium, okay, low phosphate, but parathormone levels will be high. Whenever parathormone levels are high, ALP level will be high. So now do you understand why I exclude this vitamin D deficiency? Because here it is said that PTH level is normal. Okay, it should have been elevated if it was vitamin D deficiency. Similarly, vitamin D dependent rickets type 1. This is because of 1-alpha hydroxylase deficiency. Even in this case, you will see exactly the same. Normal calcium, low phosphate, high parathormone, high ALP. But here you see normal parathormone. Okay. Vitamin D dependent rickets type 2, which is an end organ resistance. It is vitamin D hormone receptor resistance. Even in that case, very same or very similar biochemical manifestations. So whenever you see low phosphate to be accompanied by normal parathormone, then you should suspect what? Hypophosphatemic rickets. Now what is hypophosphatemic rickets? It is because of the defect of PEX gene. Okay, what is PEX gene? It is a phosphate regulating endopeptidase coding gene. Yeah, what does it code for? It codes for a protein which is responsible for phosphate regulation, and it's an endopeptidase. And what is the role of this endopeptidase? It degrades FGF23 and it degrades osteopontin. Yeah, what are the two proteins degraded by the PEX protein? It degrades FGF23 and it degrades osteopontin. What does FGF23 usually do? FGF23 causes phosphaturic effect. It causes phosphate secretion. And what does osteopontin do? Osteopontin decreases mineralization of the bone. So when there is PEX gene mutation, there is no degradation of FGF23. So there is excess FGF23 and there is excess osteopontin. So there is excess phosphate secretion causing hypophosphatemia. And that is why the name hypophosphatemic rickets. Okay. And when there is excessive bone mineralization getting affected, no bone mineralization at all. So that is why you see genu valgum and many other bony abnormalities. Okay. But there is no reason for PTH level to be elevated here. Yeah, why will you not see PTH level to be elevated? Because you see normal calcium. Calcium metabolism is not affected at all. When calcium level is not affected, parathormone levels will be normal. So whenever you see normal calcium, normal parathormone with low phosphate, and that to be accompanied by ricket-like manifestations, what will you suspect? You should suspect hypophosphatemic rickets. Do you all understand this? Okay, so the answer here is choice A. So this question was discussed in the chat box repeatedly, right? So methotrexate used causing reduced synthesis of TMP. So why will it reduce the synthesis of TMP? Because methotrexate inhibits dihydrofolate reductase. How patiently? I do get angry, but occasionally. Okay. So methotrexate inhibits dihydrofolate reductase, without which tetrahydrofolate cannot be synthesized. Without tetrahydrofolate, uridine cannot be converted to thymidine. Okay, so what will not be formed? Thymidine cannot be synthesized when a person is on methotrexate. So this MCQ, Lineweaver-Burke plot, asking you to find out which type of enzyme inhibition it is, right? So I've always asked you, whenever you're given a graph, check what is along x-axis and what is along y-axis. Along x-axis, you have 1 by substrate concentration. Along y-axis, you have 1 by V. Now check which is the line that you get in the absence of inhibitor. So this is the line in the absence of inhibitor. This line touches the y-axis at Vmax. Yeah, touches the y-axis at 1 by Vmax, and it touches the x-axis at 1 by Km. Okay, so this is the 1 by Vmax and this is the 1 by Km of the enzyme which is not inhibited. Now what happens in the presence of this inhibitor? In the presence of this inhibitor, Vmax is still the same, right? So Vmax is unaltered. But what has happened to Km? 1 by Km is reduced. When 1 by Km is reduced, Km is increased. And in which type of inhibition have I taught you? That Vmax will be unaltered but Km will be increased. That is competitive inhibition. So what is the right answer, all of you? The right answer here is competitive inhibition, because Vmax is unaltered and Km is increased. Okay. Patient underwent gastrectomy. Which of the following deficiencies may occur? So following gastrectomy, the person is prone to develop B12 deficiency, because without gastric mucosa, intrinsic factor release cannot happen. Without intrinsic factor, B12 absorption is affected, right? So B12 malabsorption. So that's all about the 31 MCQs that were given to me, and I think one more MCQ was added by you all. So totally 32 MCQs in biochemistry. Most of these MCQs, 50% of clinical biochemistry MCQs, which you will be able to answer had you learned biochemistry conceptually. Okay, so the take home message for all of you who are watching this session is that you have to you have to learn biochemistry conceptually. Do not think of biochemistry as just a preclinical subject filled with cycles and pathways. Cycles and pathways actually constitute less than 15% of what actual biochemistry is. Okay. After you're done learning these pathways, you should start applying these pathways. Only then you'll start relishing the subject. Okay. So thank you all. See you sometime later in another YouTube session.